Hello, good evening, everyone. Welcome back to my IVF&x and the European Fertility Society. We are back. Once again, I'm really happy to be here with you. Once again, we had an event yesterday, and I'm really happy to be here today and discuss totally different topic, but I know that some of those things are definitely connected. And today we will talk about recurrent implantation failure. Yesterday it was PGTA, and I think we will have a chance to also mention that option. So I'm really happy to be here with you. And as you can see, our guest speaker, Dr. Athanasios Pantelis, is with us. Hello, Dr. Pantelis. Thank you so much for joining us. This is your first time here with my IVF&x. So I'm really excited to have you, and I'm looking forward to what you will discuss today. How are you? How was your day? And are you ready to educate us?
Good evening, Caroline. I'm very, very well. Thank you for asking. I really thank you so much for your kind invitation. It's a great pleasure for me to be tonight with you in order to present to you some of my evidence and some of my personal experience regarding the recurrent implantation failures in the IVF.
Definitely. As you know, we are always happy to be able to bring any topics, of course, so that you can learn, you can ask your own questions. And today is no exception. And this is a tough topic for sure. And today it's also a special event because we will discuss success stories, IVF cases on real patients. So I think that is always nice for patients to be able to see what has been done to achieve pregnancy and what can be done sometimes. Of course, those are definitely difficult cases. So thank you so much for bringing this up. And of course, first we will start with the presentation where Dr. Pantelis will simply explain recurrent implantation failure causes, etc. But of course, he will also share the cases which we are definitely looking forward to hear about. And let me just remind everyone that this is recorded. This is anonymous. So after the presentation, you will have a chance to ask your questions. So don't hesitate. We are simply here for you. And I'm sure Dr. Pantelis will be happy to answer and help you out as much as possible. And let me just also remind that Dr. Pantelis is the fertility specialist at NewLife Greece. So we are happy to have you. This is your first time, and I'm really looking forward to just hear what you have prepared. So let's get going. I think that everyone is ready. And remember, if you have questions, please remember to type those questions in the chat. And I guess we can start sharing the screen so we can see your presentation.
Thank you so much for the introduction. Well, what is the definition of recurrent implantation failures in IVF? Recurrent implantation failure refers to the failures of embryos to get implanted into the uterus after multiple IVF attempts. It seems that affects a significant proportion of IVF patients, leading to emotional distress, to increased healthcare costs, and challenges in treatment of such a population. It seems that the recurrent implantation failure affects a significant proportion of IVF patients, leading to emotional distress, to increased healthcare costs and challenges in the treatment of such a population. It is estimated that around 20 to 25% of the IVF patients experience recurrent implantation failures. Usually, as recurrent implantation failures, it is defined as 3 or more failed IVF cycles, failed embryo transfers with high-quality embryos. Of course, in order to define more precisely the recurrent implantation failure, a clinician has to take into consideration the stage of the embryo development. We are talking about only embryos in the blastocyst stage. We need also to know if these embryos are genetically tested or not, and of course, the embryological classification of the embryos regarding their morphological criteria that these embryos meet. Finally, it is absolutely important to exclude any other causes that may lead to implantation failures, as any anatomical issues of the endometrial cavity, any uterine abnormalities, derived from a poor egg quality, etc. The main factors that may contribute to recurrent implantation failures are the following four. First category is the so-called embryonic factors. Any potential chromosomal abnormalities of the embryos, bad quality of embryos, or embryos in primitive stages of embryo development, and of course potential gene mutations to the embryos, may be the main cause for implantation failures. Second big category are the maternal factors. In this category, we may face issues that affect the endometrial cavity, such as the submucosal fibroids, the endometrial polyps, the septum of the endometrial cavity, the thin endometrium, the non-receptive endometrium, or the endometrium lining that do not respond properly to the estrogen intake. In some cases, the poor blood flow of the endometrium and finally the chronic inflammation of the endometrial cavity. Third big category is the so-called immunological factors. Here belongs all these autoimmune conditions that may affect the receptivity of the endometrium, such as antiphospholipid syndrome or the elevated natural killer cells in the endometrial cavity. Finally, in the fourth category belongs all the potential genetic factors, either from maternal or paternal origin, that may influence the quality of the embryos. Regarding the endometrial factors, it is well known that the receptivity of the endometrium contributes at a percentage of around 20% in the embryo transfers for a positive outcome. Instead of the embryonic factors, that seems to contribute around 80% for the implantation and an ongoing pregnancy. So the timing and the quality of the endometrium are critical for the embryo implantation, with optimum thickness between 7 to 12 millimeters, as it can be measured by an ultrasound scan. The vascularity of the endometrial cavity, as it can be assessed by the Doppler phenomenon, it seems that it impacts the uterine environment and may influence the potential implantation of an embryo. It is well known the recent years that any dysregulation of the immune system can lead to implantation failure or sometimes to abortions, to miscarriages in the first trimester of a pregnancy. Also, the elevated natural killer cells in the endometrial cavity seems that may hinder implantation, and of course, some autoimmune diseases such as lupus erythematosus, the thyroiditis Hashimoto, and the antiphospholipid syndrome may also contribute to recurrent implantation failures. In the last years, with the improvement of the technological circumstances under which biopsies are performed in the context of pre-implantation genetic testing of the embryos, the chromosomally abnormal embryos can be very easily detected, identified in the lab. By such an approach, these embryos that are carriers of aneuploidies can be thrown away and finally achieve to reduce the chance of failures of implantations with embryos that are genetically abnormal, although their morphological criteria seems to be perfect. Regarding the proper investigation of a case that suffers from recurrent implantation failures, all the recent literature proposes that this investigation, it must include karyotyping of parents from peripheral blood, pre-implantation genetic testing of the embryos for potential chromosomal abnormalities, diagnostic hysteroscopy of the cavity for investigation about any potential lesions of the cavity, such as the fibroids, polyps, septum, lesions indicative of chronic inflammation of the cavity. Biopsies of the endometrium for CD138 lymphocytes, for natural killer cells, for antiphospholipid antibodies, tests for autoimmune conditions from peripheral blood, and sometimes the endometrial receptivity assay, the so-called ERA test, after proper preparation of the womb for identification of the window of implantation. Regarding the findings of the investigation of recurrent implantation failure cases, there are specific scientific proposed approaches that can lead to success stories. If the parental karyotype is abnormal, of course, the PGTA, the PGTM, or the PGTSR of the embryos, depending on the findings, are the only way to identify embryos that are not chromosomally or genetically normal. If the investigation of the cavity is indicative of chronic inflammation, proper treatment with antibiotics and lactobacillus intake may improve the chances for implantation and a clinical pregnancy. In the cases that are indicative of anatomical lesions of the womb, operative hysteroscopy, surgical intervention, removal of the fibroids, of the polyps, or of the septum can be proposed, can be advised. The corticosteroids, the intralipid infusion therapy, or low-dose aspirin in patients with elevated natural killer cells or autoimmune issues may be the gold standard approach in these clinical cases. The last years, the so-called co-culture of the embryos with endometrial cells is an experimental technique, and it has been used in IVF treatments in order to enhance embryo development and implantation rates. The idea is to create a more physiological, relevant microenvironment that mimics the conditions of the embryos that encounter in the human uterus. The mesenchymal stem cell holds significant promise for the future for treating also endometrial dysfunction and enhancing implantation in IVF. While preliminary data is encouraging, especially for patients with few alternatives, larger, well-controlled clinical trials are still needed in order to properly determine the safety, the efficacy, and the long-term outcomes of the mesenchymal stem cells-based treatments. Although the last years we have seen huge improvement in the IVF treatments, the recurrent implantation failures unfortunately remains a complex and poorly understood issue with varying success rates for different treatment protocols. We hope that to the recent future, by the use of genetic screening, by personalized embryo transfers, and with the use of immune modulating treatments, we can face much better outcomes in the women that suffer from recurrent implantation failures. At this point, I'm going to present to you 3 clinical cases that I handled with the last year in my clinical practice and used to suffer from recurrent implantation failures. The first case talks about a 38-year-old woman with a 42-year-old partner. It was a couple that used to try for approximately 2.5 years for a spontaneous conception. They failed to conceive. From the investigation of their fertility, they have been diagnosed that suffered from male factor of infertility. From the male, we used to have oligoastenoterato-zoospermia. On the other hand, from the female side, everything seems perfect regarding her age. I have performed an IVF treatment, a stimulation at an antagonist protocol. I have stimulated her ovaries with 225 international units of a regimen that both contains FSH and LH. I have collected, after 10-11 days of stimulation, 12 eggs. 9 of them were mature. 9 of them have been microfertilized with a corresponding number of spermatozoa. Parenthesis, we have used also a sperm sorting device due to elevated GFI of the sperm. And the final outcome in the lab was 4 blastocysts on day 5 stage and 1 more on day 6, totally 5 embryos. I have started, all of these embryos have been cryo-preserved, and after 1 or 2 months, I have started to prepare the endometrial cavity in order to perform the frozen embryo transfers. Unfortunately, this woman had 3 in a row single embryo transfers with negative outcome, totally negative. In terms of investigation of this kind of recurrent implantation failures, I have performed a hysteroscopy, and I have taken also biopsies for CD138 lymphocytes. From the hysteroscopy, as you may see, all these strawberry-like lesions in the right side of the uterus shown chronic inflammation of the cavity. Also, the CD138 lymphocytes were positive, so I have prescribed to her triple antibiotic treatment with ciprofloxacin, with metronidazole, with doxycycline, and after this fulfill of the treatment, after 2 months, I have tried once more to prepare the endometrial cavity and performed another one single embryo transfer with positive outcome, with a clinical pregnancy, and of course with a live birth. Second interesting clinical case, it was a 45-year-old woman that she was performing egg donation process with her partner's sperm. She has decided to make an IVF treatment with egg donation process due to menopause. From her medical history, she used to have 2 previous spontaneous conception with a previous partner. Both of them led to a miscarriage. We have identified a proper young donor for her. We have stimulated the ovaries of the young donor. We have collected totally 12 mature eggs, 12 eggs in the metaphase 2 stage. The young donor aged 26 years old, and she was of proven fertility. She used to have already a kid. All of these mature eggs of the donor have been microfertilized with a corresponding number of spermatozoa of partner sperm, and the final outcome was 6 totally embryos in the blastocyst stage. All of these embryos have been cryopreserved, and the next month, when the recipient was ready, we have started the preparation of her endometrial cavity to a medicated cycle, estrogen pills per mouth, 1 or 2 scans in order to see the thickness of her endometrium, 5 days of the progesterone intake, and finally the embryo transfer. I have totally performed 1 double embryo transfer and 2 single embryo transfers, totally 3 embryos of such an origin of egg donation process that unfortunately used to have a negative outcome. In terms of investigating why she suffers from recurrent implantation failures, I have performed a diagnostic hysteroscopy in the proliferative phase of her cycle. Everything was totally clear. And to the secretory phase of a subsequent cycle, I have performed the so-called ERA-EMA-ALICE test. The number of lactobacilli was a normal one. It was not indicative of a chronic inflammation. But from the ERA test, from the endometrium receptivity assay test, it has been shown that the endometrium was receptive 24 hours later than we prepared her endometrial cavity. So we have applied the ERA protocol to a next single embryo transfer with a success story. The third case talks about a 42-year-old woman that she was trying to become pregnant with her own eggs, although her low AMH levels, and a donor sperm as she was a single woman. I have performed to her totally 4 stimulations, 4 cycles. From the first cycle, I have retrieved totally 5 eggs. 2 of them were mature to get microfertilized, 1 J5 embryo, finally derived with negative outcome. From the second IVF attempt, we have totally retrieved 4 eggs. 3 of them have been microfertilized. Once more, we used to have just 1 blastocyst that has been transferred fresh to her womb with negative outcome. From the third IVF attempt, after many conversations, the 42-year-old woman decided to perform pre-implantation genetic testing of the embryos. I have retrieved totally 7 eggs. 5 of them were fertilized. 2 of them have become embryos in the blastocyst stage, but when they have been checked in the lab, both of them were chromosomally abnormal with complex abnormalities. One last attempt of IVF with 5 retrieved eggs, 3 fertilized, 1 day 5 and 1 day 6 blastocysts, embryos, once more for PGTA, and unfortunately, once more, another 2 embryos were genetically abnormal, were chromosomally abnormal. So we totally used to have 2 unsuccessful fresh embryo transfer cycles and 4 PGTA tested embryos that have been found abnormal. The endometrial lining always was a trilaminar one between 8.5 to 9 millimeters. And after all of this, the woman decides for an embryo donation, an embryo that has been derived from a young donor, microfertilized with a donor sperm. We have transferred 1 day 5 embryo with positive outcome, of course, with clinical pregnancy and a live birth. As you can imagine, the IVF patients that face recurrent implantation failures often feel stress and anxiety. These women may feel extremely depressed and disappointed with the negative outcomes of an IVF treatment. It is very important for these women to seek for help. There are support groups or professional counselors that can manage this kind of emotional distress. It is extremely important for these women to understand that at this journey for parenthood, they are not alone. They must know that at this journey, unfortunately, some of them will face unsuccessful treatments. But they must know also that in almost all of the cases, they can achieve finally a success story. In conclusion, the recurrent implantation failure in IVF is a multifactorial issue. It requires individualized treatment approaches. Advances in the embryo selection, in the immune modulation and personalized medicine have shown promise for the future. The ongoing research into genetic, immunological, and hormonal treatments could lead also to better solutions for recurrent implantation failures. And I suppose that the continued research and patient-centered care are essential to improve outcomes for individuals struggling with this condition, the so-called recurrent implantation failures. Thank you so much. This was my presentation. I am available for your questions.
Brilliant. Thank you so much indeed for your presentation and showing us also the cases, because I think that most of the patients are definitely looking forward to listen to some success stories. That's the truth. So thank you a lot for bringing this up. There are some ways that this can be overcome. So thanks. And as you can see, there are some questions in the chat, so we will go through them one by one, so you can keep them coming and we will definitely take care of those for you. Before we actually start your questions, I will give you a little bit more time for putting the questions in the chat. I would also like to ask you, because we also receive quite often the question in regards to endometrial tests like Emma, Alice. Is it recommended in recurrent miscarriage? Do you use those particular Emma, Alice tests, or perhaps you are using some other tests as well?
To be honest with you, The RIM ALICE test, this kind of triple test, it was something that all of the clinicians used to recommend it in plenty of cases that suffered from recurrent implantation failure. The recent years, before 1.5 years, it has been announced a very big randomized control trial by which the recent literature says that maybe it is something that it has not been recommended to most of the cases, because when you identify the so-called window of implantation to a specific cycle, this does not mean that every woman, every month, has this specific window of implantation, the specific days. And the last 1.5 years, to be honest with you, most of the clinicians, we start to minimize our recommendations regarding this specific test.
Yeah, crystal clear. Thank you so much for making this clear for patients, as well, as I know that many times we receive this kind of question. And let me now go to the questions that we've got here. After PGTA testing, the first question was significant, because you said at the very beginning, don't remember exactly, but significant proportion. Can this be put in percentage? And the follow-up question here is actually, so, and after PGTA, it's about the recurrent implantation failure. After PGTA testing, also still 20-25%. Are you able to tell us from this information here?
Yes, of course, I can answer it. We know by default that when we are transferring one embryo that has been genetically tested, that it is euploidic, normally in the chromosomes, the chance for a woman to become pregnant is approximately 55 to 60%. With 3 genetically normal embryos, with 3 PGTA tested embryos, the chance for a woman to become pregnant reaches approximately 92-93%.
Yeah.
So according to the recent evidence, as the ESRE recommends, 3 euploidic embryos rises extremely high the chance for each woman to have not only a positive pregnancy test, but also a viable pregnancy till the end.
Okay, thank you so much for the clarification for your question. And now, in regards to adenomyosis, what protocol is better? If someone has adenomyosis, this is the information. What protocol is best, yeah, to achieve pregnancy?
The adenomyosis is a very often a medical condition that affects many women. It is said that women that suffers from adenomyosis in their uterus, unfortunately, they have diminished chances to have an implantation. In these cases, all the recent guidelines recommend to cryopreserve the embryos, to down-regulate by down-regulation depot injections the adenomyosis, and then perform to a medicated cycle the embryo transfer. If we down-regulate it, if we manage to suppress this kind of disease, like adenomyosis, it is said that the chances for a woman to become pregnant are similar with those that do not suffer from this condition.
Okay, again, thank you so much. More questions are coming in, so thank you a lot for that. And I want you to see, because there are some details here. So my husband has high sperm DNA fragmentation. Comet test indicates that the fragmentation rate is 39%. I heard that NewLife uses microfluidic sperm selection technique. My question is, can my husband overcome the DNA fragmentation issue with this method, sperm selection technique? Anything you can advise here?
All the last years, in all the IVF clinics, as we know, in cases where we faced men with elevated DFI, we were trying to treat it by giving supplements and vitamins and all these things. The last 3.5 years, in the labs from the embryologists, there are specific sperm sorting devices. They work like a kind of filter in which they pass the filter on the day of the sperm collection. From this filter, somehow the embryologist can identify not only the spermatozoa that are motile, not only the spermatozoa that are morphologically normal, but moreover the spermatozoa that do not have elevated DAFI. So the use of these sperm sorting devices becomes, the last years, more and more popular in all of the labs. We use them approximately 2.5, 3 years, and roughly I can say we have totally bypassed such an issue from the sperms.
All right. Okay, thank you. If there's anything else, if you have any follow-ups, you know what to do, go ahead. But I'm sure you can see that more questions are coming in. Some have some more details again, so let me just show it to you. I have had 5 pregnancies spontaneously but miscarry between 8 and 12 weeks. I have never had implantation from IVF, 5 days blastocyst, 1 fresh transfer, 2 frozen transfer. Any explanation? Are you able to provide any explanation to that?
Well, according to today's knowledge, the genetically abnormal embryos usually have the tendency to miscarriage before the fulfill of the 9th week of the pregnancy. Most of the genetically abnormal embryos either could not give an implantation, or if a woman becomes pregnant, she will suffer from a miscarriage, from an abortion, either if this pregnancy came by an IVF treatment or spontaneously. So this woman talks about spontaneous conceptions, that all of them led to miscarriages. Miscarriages between 8th to 12th week, correct? One of the main issues that we face very, very often with late miscarriages after the 9th week of the pregnancy are the so-called thrombophilias, are the so-called antiphospholipid syndrome. The antiphospholipid syndrome, women that have positive lupus anticoagulant or antibodies against the cardiolipins or antibodies against the beta-2 glycoproteins, women that for sure suffer from this condition, have the tendency to abort after the fulfill of the 9th week. Now, this woman talks also about that after these spontaneously pregnancies that miscarried, all of them, she never had implantation from an IVF with blastocysts, 1 fresh, 2 frozen. I suppose that the implantation failures were either due to genetically abnormal embryos, or I don't know if something happened regarding her endometrial cavity. You may know that after many miscarriages and all these things, sometimes women secondary after a miscarriage can have an inflammation in the cavity. So I suppose that this specific case for sure needs a good investigation of her endometrial cavity. And if she will keep on trying with an IVF, in her case, I would recommend to perform pre-implantation genetic testing of the embryos.
And actually, sorry, there is another part from Gemma here, okay? So it's a different question, but I think that we also have the age here, 44 with own eggs, and what is your view on fresh day 3 transfer versus frozen blastocyst transfer? Any views on that you can share with us as well?
Yes. The embryos in the 5th day of embryo development, or in the 6th, in the blastocyst stage, it seems that have double chances to give a pregnancy instead of the day 3 embryos. As we all know, the embryos till the 3rd day of embryo development usually express the genetic material from the maternal side, from the woman's side. On the 4th and on the 5th day of embryo development, on the cell divisions, usually it is started to get expressed the genetic material from the paternal side, from the male side. Embryos that cannot survive in the lab till the blastocyst stage, for sure cannot survive also in a woman's womb. when we leave the embryos to get cultivated till the blastocyst stage, finally gives to a woman double chances to have a pregnancy instead of the same embryos in the third day.
Yeah. Okay. Thank you. I believe that explains it. But of course, let us know if you wish to add anything else. Question from Sasha: how many attempts does it usually take for a 44-year-old using ONX? Excuse me. 44. How many attempts does it usually take for IVF with ONX? Yeah, this is the question.
It said that for women that are aged over 42, 43 years old, we need approximately 20 mature eggs in order to finally have one embryo that will be genetically normal, one embryo that will be chromosomally normal.
Mhm.
Some women, they will manage to find it, to identify such an egg from their first attempt, some others from their second, some others from their third. Unfortunately, it seems that we need to collect as many eggs as we can to microfertilize them in order to finally have one embryo be normal.
Okay. Yeah. Thank you so much. Thank you. Again, let's have a look. More details again. So I will show it to you. I had laparoscopy, hysteroscopy after 2 failed IVF cycles, which resulted in 3 failed embryo transfers. Laparoscopy revealed that I had stage 2 endometriosis. I also had a small scar tissue. These were treated by laparoscopy and hysteroscopy. I'm 28 with AMH 1.13. Do I have any chances of natural pregnancy? How long should I wait for another cycle after laparoscopy and hysteroscopy? A few questions in one. Let's try to answer them one by one, okay?
If from the laparoscopical approach from the doctor, the endometriosis has been treated properly, and if both of the fallopian tubes are open, as this woman is young enough, although her low AMH levels, I would recommend to try for at least 6 to 9 months for a spontaneous conception. If she failed to conceive, yes, in this case, due to her low AMH levels mostly, it will be worth it for her to try once more with a new IVF treatment.
I think it's clear as well. But of course, again, if you have anything else, you know what to do. Let's have a look at the next question. Another more details here from a different patient, right? So I have had 9 failed frozen embryo transfers, 1 successful French transfer. I'm 46, have 8 frozen embryos. I'm looking to move them to your clinic with a fresh cycle mixed with frozen embryo transfer. How much time do I need for investigation before I can have the transfer?
9 failed frozen embryo transfers and 1 successful fresh.
Yes.
Okay. And all of these cycles have been performed with own eggs at 46 years old. What kind of embryos are them?
Yes, waiting. Someone is typing, so I believe the patient is own eggs. Yeah, for sure, own eggs.
Own eggs.
And yep. And let's see if you have anything else. You know what to do. Go ahead, type this in.
Regarding these repetitive failures,
Excuse me, before the age of 42, right? So, and now she's 46, right?
Okay. They have been collected at 42 years
Yeah.
old.
Yeah.
Of course, these frozen embryos, before started to transfer to the uterus, she needs an investigation regarding these failures of the frozen embryo transfers. I suppose that for sure she needs a good hysteroscopy. I suppose mainly for chronic inflammations and all these things. And if the investigation of the uterus is totally clear, I suppose that the main reason for all of these attempts was the chromosomal potential abnormalities of the embryos. Maybe at these cases, it will be worthy for such a woman to thaw these embryos, to make biopsies, to cryopreserve them, and test them in order to identify one or if she's lucky, 2 embryos that will be chromosomally normal.
Yeah, there's another information. Yeah, I have fibroids. The embryos were not tested. Yeah, so it would be good to actually test them then. Yeah. Okay. If there's anything else, go ahead, type this in. Yeah, I will go to the next question, and I'm sure we can. There's one follow-up more here from the same patient. Is it a good idea to have a mix frozen embryo transfer and fresh together?
Mixed
This is the
embryo
question from the same patient.
transfer, we mean embryo that has been taken now from a stimulation or from a natural, whatever, and to combine it with another one embryo that has been cryo preserved. Yes, of course.
Yes.
It is.
Okay. It would be.
In order to elevate the chances for a woman to become pregnant, of course.
Okay. Okay. Thank you. Let me know if there's anything else you wish to add. And now we will move on to another question, bit of a longer question with some details. So just give me a second. I need to scroll down. Here's the question. So I had 6 PGTA good tested embryos, first implanted and positive after 6-7 days, then negative test after 12 days. No aspirin or immunosuppression medicine in plan. Clinic said it was already in progesterone, so with 90% probability after 2-3 transfers, we should just continue or have camera examination. Perhaps, I assume blood test next day will show inflammation. Anything you can advise here?
The 6 PGTA tested embryos that were normal, as I can understand, they have transferred just one that miscarried, correct?
Yeah,
so
let us know.
Another 5 embryos that are genetically normal. Yes, correct. The probability to have a terminal pregnancy if this woman needs to transfer another 2 chromosomally normal embryos reaches a probability of 90%. In this case, I would recommend just to make a hysteroscopy and nothing else.
Okay. Peter, if there's anything else, you know what to do, because he confirmed just one transfer. Yeah, so thank you. Someone is typing, so possibly we'll continue. We will get back to this question, and let me go to the next one. In the meantime, during the hysteroscopy, a swab was taken for NK cells and histeropathology. What is the difference between NK cells by blood and biopsy? I had no NK cells abnormalities but one of my regulatory T cells. If I come to NewLife for IVF, what will you do to treat abnormal T cells?
It seems that the natural killer cells can be identified, of course, also in the blood and in the uterine cavity. It seems that the natural killer cells cannot be accepted if they are elevated in the blood because they can be indicative of plenty of potential diseases, autoimmune diseases. We need to clarify them only if we can identify them in the womb, in the woman's womb, in the uterine cavity. In the cases that we identify natural killer cells elevated in the uterine cavity from biopsies, in these cases, we recommend for this woman to an embryo transfer to start to take corticosteroids per mouth in order to diminish this kind of elevated to suppress this kind of elevated autoimmune response. And moreover, we recommend the so-called infusions of intralipids. Usually, we are performing one first infusion on the day of the embryo transfer. We recommend to perform it once more on the day of the positive pregnancy test. A third infusion in the fulfill of the 8th week of the pregnancy, and the last one in the fulfill of the 12th week of the pregnancy. Totally 4 infusions in order to suppress these elevated natural killer cells.
Okay, Again, lots of details. I hope that was useful. I do believe so. Thanks a lot for that. Next question, a short one. We discussed sperm DNA fragmentation. What sperm sorting mechanism are you referring to? This is the follow-up. And is it max or microchip?
I don't know how it is called, if it is max or micro.
Sure.
The most familiar, we use at our clinic, it is the so-called Zymont. I don't know what exactly category it belongs to. Maybe a technician from our lab, an embryologist, could answer more precisely this question.
Yeah, okay. And just to clarify, because we mentioned this, but I understand you said that it's totally possible to overcome high sperm DNA fragmentation using sperm sorting technique. Is this correct?
In extremely high percentage.
Yeah, so thank you for the reassurance. I just wanted to, show it to you. And now, again, I have a longer question from Anna. As you can see, there are some details. I've done 10 embryo transfers, in total 6 great blastocysts but untested, plus 4 tested and were euploid. I've had all the possible tests done, including a deep immunological panel, diagnostic laparoscopy. Nothing was ever found. My cycle is super regular, no GI issues or inflammation, and everything looks good on my husband's side. We've been trying to conceive since we were 30, 7 years ago, and in treatment for 6 years now. I've had 2 miscarriages, 1 chemical, 1 at 9 weeks. We have just 1 embryo euploid left, and we'll be transferring it after 2 months of suppression. It will be our last chance. Have you seen anything like that before? What chances do we have?
I have faced, to be honest with you, 1 or 2 cases similar, like Anna's case, unfortunately. With 4 euploidic embryos cumulatively, the chance for such a woman, for you, Anna, to become pregnant were extremely high. But as I see, unfortunately, you have just 1 euploidic embryo. As you have examined everything, as you have already performed full investigation of the recurrent implantation failures, the only way to change something, I don't know how you were performing this kind of embryo transfers, if it was in medicated cycles or if these transfers were in natural cycles. I would try once more by a different way. If all of them were in medicated cycles, sometimes another approach is to make an embryo transfer in a natural way, in a natural manner. It needs much more often monitoring by the hormones, by the ultrasound scans, but sometimes it gives to us better outcomes regarding the implantation rates instead of the medicated cycles.
Anna added, we used both ways, natural and medical cycles. This is the additional information, yeah.
She has used both of them.
Yep, natural and medical cycle, yeah.
As she has already fulfilled all the investigation, I cannot think about something extra, just to try once more.
Yeah. And of course, as always, remember that I'm sure Dr. Pantelis would need to see all the results, etc., just to give you a proper answer. Of course, so of course, we are here to answer your questions, but I'm sure more details, more are needed to provide you with some, again, possible advice, more advice here. So please remember that. And thank you. I do hope that was useful. Lots of questions today. Thank you so much indeed. And so let's have a look. We have another question here. Above what level of NK cells in endometrium biopsy do you give corticosteroids and intralipids? Do you suggest G immunoglobulin, and in which cases, and how many days before embryo transfer?
This is something that can be very easily answered by the immunologists. To be honest with you, in these cases that we have positive natural killer cells, I recommend to take a more precise answer from specific immunologists.
Yeah,
I cannot
that makes
answer it.
sense.
I don't know it.
Definitely, it's always best to, especially that it's always like that. It's the same if you get a question from for an embryologist, etc. Right? So it's better to double check it. Definitely. Do you prescribe medication for those who come to NewLife with immunology issues? If so, what sort of medication do you prescribe as well?
Medications for those who come with immunology. If so,
Yeah.
no, I never prescribe except from corticosteroids per mouth and infusions of intralipids, nothing else. If a case is suspicious for specific autoimmune problems, I would prefer to recommend it to a specific immunologist, to a specific doctor, to a specialized one.
Yeah, of course. We did receive one more. Do you prescribe prednisolone?
In some cases, yes. In cases that for sure suffer from autoimmune diseases, and in some cases that from the investigation of the endometrial cavity, I have identified elevated natural killer cells.
Yeah. Okay, brilliant. Thank you. Thank you so much. Lots of questions today. So thank you a lot for that. We will go to the next one. What do you recommend when you had 3 spontaneous abortions before 12 months, all natural pregnancies? Only a few months later, at 40, I started IVF treatment 3 times with good quality, but never got any positives. My partner had altered fish with diploid spermatoids, then tried egg donation, double donors in natural cycle without a positive. Anything you can advise?
Maybe to change the donors, nothing else. I cannot believe that a woman's womb, a woman's uterus cannot have an implantation if the genetic material of the embryos that have been transferred in the uterus were genetically normal. It is a matter of time. Sometimes we are performing double donation embryos, transfer of double donation embryos, and although we are waiting to have the positive pregnancy test from our first attempt, unfortunately, in some cases, they have difficulties to have a conception. I have seen some cases from my experience that when they have changed the donor, the egg donor or the sperm donor, they have achieved to have this kind of positive test.
Yeah. Okay, thank you once again. Okay, sorry, lots of questions. I'm just trying to look through them. And let me just go to this question. So does cryopreservation, of embryos 4-5 months decline quality?
Nowhere.
Yeah.
Nowhere.
Crystal clear, right? It's still the same quality, of course, right? So you shouldn't worry about that. All right. How many scans do you do at the clinic, NewLife clinic, during the IVF simulation? Do you give blood thinners, progesterone, prednisolone, etc., to support embryo implantation?
For the stimulation, we are performing the first scan with the woman's bleeding. We are performing the scans on day 5, on day 7, on day 9. As you may know, most of the women around day 10, day 11, day 12 maximum are ready to collect their eggs. This was about the scans. And the other question was...
Sure.
Just a minute to find it.
Yeah, sure. I will show it to you. Just need to go back.
If we give corticosteroids, I suppose, only in the cases that they suffer from specific autoimmune diseases.
Yeah, sure. Thank you. Thank you so much. Lots of questions today, so sorry about it, but of course I now see it here as well. Okay, and there are 2 questions here. So is there like a maximum number of IVF attempts and whether it can cause IVF itself, right? Does IVF cause cancer?
The IVF attempts can be divided to stimulated cycles, to natural cycles, to donations, and all these things. I suppose that the question talks about the stimulations, correct?
Yeah, possibly, yeah.
It is said that after 6 stimulated cycles, from each case, a doctor can achieve the maximum chances to have a pregnancy from a woman's genetic material. Of course, this is something relevant because it has to do with the number of the follicles that each woman contains. It has to do with the number of the eggs that a doctor can retrieve from each case. It is totally different to give a stimulation to a woman that has totally 4 follicles from both ovaries. It is totally different to give a stimulation to a woman that suffers from polycystic ovarian syndrome and she's going to give to you 30 or 40 eggs. There was a theory before many years ago that the excess of estrogens that are produced from the follicles may trigger a potential estrogen-dependent cancer. But we know the recent 10 to 15 years that this is not how it works, because the potential pregnancy, the estrogens that can be produced from a placenta for 9 months, it is much more bigger in dosage, and it circulates in a woman's blood for 9 months and not for 10 days in order to collect the eggs. This is why, on the last 10 years at least, women that suffer from cancer are recommended from the oncologist pathologist to visit IVF clinics, to take exactly the same stimulation in order to collect their eggs before to start the chemotherapy treatments regarding their cancer. All the stimulations, all the estrogens that can be produced from the follicles cannot provoke a cancer in the future. The science, according to today's knowledge, has a definite answer about it.
Yeah, thank you so much. It's really important to remember that. I do see more, sometimes, of course, we do see these questions. I'm really happy that we were able to also clear this out. And there's one more question, actually. Does chemotherapy destroy acceptability of the endometrium? And is there a test like that can show it?
The chemotherapy may destroy the genetic material of the egg. But according to my knowledge, as I know, the chemotherapy cannot destroy the acceptability of the endometrium to have an implantation.
Yeah. Thank you again. Thank you. And now I will go back to the previous question that we did receive, and you can see this is the first question from the patient who was 28. You see the details here, and there's a follow-up, right? So my fallopian tubes are normal and open. The endometriosis was excised as much as possible without causing any risk to bowel and bladder. The surgery was done in Athens. Now I am planning to move to NewLife. Sometimes I feel that I cannot have a baby as previous 3 number transfers failed. 28, I'm willing to have another 5 IVF cycles if needed. So do you think I can have a baby with my own eggs somehow at some point?
I'm totally persuaded that such a case can have a pregnancy with her own genetic material. The AMH levels reflects to the number of the follicles that a woman can have in her ovaries. Does not say anything regarding their quality.
Yeah.
Of course, as we have diminishing the numbers, we have some influence in the quality of them, but we are talking about a very young woman, a woman that is just 28 years old. I cannot accept that such a young woman, such a young lady cannot have a pregnancy with her own genetic material.
Okay. I believe that was reassuring. I do hope so. And thank you so much indeed once more. Let's see. Next question. I have done 2 embryo transfers without success. The doctor still didn't prescribe the examination of AMH and thrombophilia. I'm 36. Should I check it? This is the
2
question.
embryo transfers without the doctor still didn't prescribe the examination of AMH and thrombophilia.
Yep.
The AMH is an index, as I have said, that has to do with the number of the follicles that each woman contains in her ovaries. If such a case, for example, suffers from polycystic ovarian syndrome, if in such a case the doctor have identified plenty of follicles, there is no need to ask from this woman to perform an AMH just to see a number. The AMH is just an index. Regarding the thrombophilias, we know, I have said before, that the thrombophilia is a condition that provokes abortions and miscarriages, usually after the fulfill of the 9th week of pregnancy. It is not a cause for recurrent implantation failures.
Okay, and I will show it to you as well. 'Cause there's another question here. Just give me a second. I need to go back. Sorry. So my AMH test was done 3 days after laparoscopy. AMH was 1.3, 13. Sorry, do you think I had the AMH test at a wrong time?
It's at the wrong time. The AMH is a hormone that can be measured independently of the days cycle, independently if a few days before a woman has performed the surgical operation.
Yeah. Okay. So basically, you can test it any time, right? There's no like specific.
Yes.
Okay, this
On
is
the
very
other hand,
important.
the remaining of the hormones have to be tested, have to be measured in specific days of the woman's cycle, like FSH, LH, estradiol, and all these things.
Yeah, because there's another question here. I will show it. I mean, I will just read it for you because it's a short one. Does a low AMH level affect equality?
It depends always it depends on the age. I'm gonna explain to you my experience. Let's say that we have 2 women, one woman that is 28 years old and she has 0.5 nanogram per ml AMH. And on the other hand, we have a 42 years old woman with exactly the same age. Both of these women, the young one and the older one, have approximately the same number of follicles reserved in their ovaries. They have approximately the same number of eggs reserved in their ovaries regarding their AMH, exactly the same AMH. But we know by default that when we are treating young women with low AMH levels, the chances for them to give a conception are slightly higher instead of the women with the same AMH in older ages.
Very important. Again, thank you. Definitely, of course. But of course, if there's anything else, you can still type this in. There are a few questions left. We will be slowly finishing. Possibly we will not be able to answer all of your questions, but as always, remember, we will be happy to just simply forward the questions to Dr. Pantelis and his team at NewLife Greece. But I still think we can answer a few of the questions. Gemma asks, do you accept exceed home semen analysis test result? I believe it's from the UK. I'm not sure, but it's possible. So do you?
Home semen analysis test results, I cannot fully understand what it means to have the ejaculation at home and bring it to the lab. If it can happen in a period of time of half an hour, I suppose that from the lab it is okay in order to examine it properly, yes.
Okay, if there's, just go ahead, type this in if you meant something else, okay? But I think that should be clear enough. How do you treat abnormal high regulatory T cells? Are you able to tell us, or this is more of a question to immunologist once again?
It is also something that I cannot
Mhm,
treat it
yeah.
properly regarding my specialization.
Yeah,
Maybe
of
some
course.
case needs an immunologist.
Exactly. And I guess you are cooperating because there are some questions in, can you refer any immunologists? And I'm sure that you are cooperating with one at the clinic as well, right? So if anyone would like that, they can just get in touch with NewLife Greece team and you will be able to also help. Right. Thank you so much, because there are some questions on that. And we will go back once again. I want to make it clear for our patients. So sorry, I didn't quite understand what you were referring to in terms of the role of paternal genetics in a blastocyst versus a day 3 embryo. Would you mind explaining? My previous clinic used to insist on day 3 transfers. Okay.
I will try to explain it once more. Mainly, till the third day of embryo development, the responsible genetic material for the cell divisions till the third day is the genetic material that comes from the woman. After the third day, on the fourth, and moreover on the fifth day of embryo development, the cell divisions in an embryo are coming regarding the genetic material of the male side. This is why we know the last 15 years at least that when we are treating cases that there is a male factor, for sure we have to cultivate the embryos till the fifth day of embryo development.
Okay, thank you. And sorry, I'm just looking still for some questions. Let me just show you once more. I mean, this is a question again that we receive quite often, so I think we can surely answer that. I'm sure you receive it. My husband travels a lot. Will sperm freezing compromise his quality if he already has high DNA fragmentation, poor motility, and morphology? Also, what supplements do you recommend to improve sperm parameters? How is it done
There
at
are
the
plenty
clinic
of
with you
supplements,
usually?
vitamins that contain everything. There are plenty of supplements that are suitable for the male factor.
Yeah.
I cannot recommend something specifically. There are
Mhm.
plenty of them. And to be honest with you, I do not truly believe that the improvement in the parameters of the sperm can be very easily done by supplements and vitamins. Sometimes we have a small improvement, maybe in the motility, sometimes in the genetic material that these spermatozoa can carry, but of course, none of the supplements or of the vitamins can improve a low concentration and, of course, the morphology of the spermatozoa.
Exactly. Thank you so much. And I would like to ask you myself actually a question because we also receive it. So basically, what is it if someone is ready, let's say, for the IVF and partner sperm is, let's say, not ideal? Do you still prescribe it and say that, okay, listen, you can take it for 3 months and then try, or maybe it's just simply better to go ahead with the treatment? How does it work?
If
Of course.
a sperm with significant good concentration but slightly lower motility, yes, it is the proper case to take supplements and vitamins.
Okay.
If we are talking about a man that has 1 or 2 millions per ml concentration, extremely low motility, morphology just 1% with a limit of 4, of course it is a straightforward case that needs ICSI technique and nothing else.
Okay, thank you. Thank you so much indeed. And as you can see, more questions are here, but I think that we more or less did answer because there are some of those questions that we discussed, let's say, already. So I think we can finish for today. However, I definitely want to encourage anyone who would like to ask anything else to just simply get in touch directly with Dr. Pantelis and his team at IVF, NewLife IVF Greece, or you can simply forward those questions to me. I'll be happy to share them. And as you know, we doctors definitely need more details from you to give you a proper answer. But thank you so much. It's been a very interesting session, and I'm sure we could spend like more than 30 or even 2 hours just to be able to answer all of your questions. But I think we can finish for today. Dr. Pantelis, anything else you wish to add? And thank you so much for joining and answering all those questions.
I really thank you for your invitation. It was very, very nice, the conversation that we have started with all of these cases. Thank you so much.
Thank you indeed, and I know that we were able to discuss many things today, and this is a tough topic, so there are plenty of parts of this, of course. But thank you again, and you can see the thank yous coming up your way as well. So thanks a lot, everyone. I just want to add that, of course, we will be back with some more details, with some more topics. Tomorrow we will actually discuss IVF for single women. So if this is something you have questions about, you can join us, and we will be discussing this tomorrow. You can go to myivfanswers.com. You will find plenty of upcoming events right there. So I hope to see you tomorrow, but also Dr. Pantelis, I'm really looking forward to some more events. It was lovely to have you. This was the first time. I hope it is not the last one. So thanks, and take care, everyone. Have a lovely evening, and hope to see you quite soon here, quite soon as well. Okay, take care. Bye.